let's get started with an agenda slide, and we'll just share a little bit more about the flow for this evening. So we'll do some quick introductions, but the bulk of the evening will be around blended capitation. What is it, and how does it support the patient's medical home model? And we're very happy to have two physicians that Dr. Flanders just mentioned sharing their experience throughout the presentation. What is it like to work in a blended capitation clinic? We'll do a small little discussion on AMA and Alberta Health Services supports that these clinics receive. And then if you're curious, we'll share a little bit more how you might get more information if you have some curiosity after the session. And then, as mentioned by Dr. Flanders, we'll just open it up for all the amazing questions that you might have in your mind after we present. So let's get started. We'll just have Dr. Brad Bahler from Sylvan Family Health Center and Dr. Melanie Currie from West Grove just come off mute for just a minute to say hello to the group and have a small little introduction of themselves. If you wouldn't mind, Brad and Mel. We'll start with you, Brad.
Sure, I'm Brad Bahler. I'm a family physician in Sylvan Lake. Been there around 20 years now. And in addition to that, I've been the medical director for the AMA ACT team for, it's almost a decade now, actually. And spent a lot of time working with PCNs in patient medical home related work and doing other quality improvement stuff in Canada. So thanks for having me.
Yeah, thanks, Brad. And Mel?
Hi, I'm Mel Currie. I'm a family physician in Spruce Grove. I practiced cradle to grave care, delivering babies, doing palliative care and hospital medicine, as well as our office. I've been at our office for the last 20 years, and we went live with Blended Cap last year because Brad made it look so amazing. So we said, sure. And then basically, I've done lots of things for AMA over the last number of years. I was also site lead at my hospital for a while. So yeah, happy to be here.
Yeah, so glad that you're here. Thanks, both of you. And we'll be continuing to chat with you throughout this evening. What we really wanted to do is make this really a conversation with those of you that have joined us this evening. Very conversational style with Dr. Currie and Dr. Bahler. And so we just thought we would just start from the beginning, what everybody always asks you, which is, why did you join the blended capitation model? Why did your clinic join? And maybe we'll just start with Brad. What was it that prompted your clinic to join? And then we'll have Mel.
Yeah, I mean, we had actually been waiting for some type of alternate model for quite a few years. And that was because we had done a lot of good work with our PCN, we felt, and leveraging PCN team members in our office. And over time, we had added in additional team members to support us through fee-for-service. But we felt we had kind of reached a ceiling where we wanted to make more progress as a team. We wanted our team to be able to do more. And, fee-for-service became kind of handcuffs in really, truly leveraging interdisciplinary care. And so that was one reason. Second reason, we've always been a bit underdoctored in my area of the world, and, several thousand unattached patients in my relatively small community. And so we felt like we could leverage blended capitation to be able to look after more people in Sylvan Lake. And that was one of our motivations as well. And then lastly, I think just as we watched the complexity of family medicine grow, really felt like patient's medical home, fully fleshed out was the way of the future. And, and kind of a bit of an anti-burnout recipe was team-based care. And so those are probably the main reasons why we chose to go forward, Carrie.
Great, thanks so much. And Mel, what prompted your clinic to go that direction?
Many of my reasons are similar to Brad's, but at the same time, I mean, for us, we had a very robust medical home already because of our distributed model with our PCN. And so that was actually kind of in place, and our PCN had been very supportive for a number of years for us. What we had started thinking about it mainly because one of the docs who actually helped create Blended Cap is one of the docs in my office. So he was basically on us all the time. Come on, guys, consider it. There was lots of issues with when it first came out, and problems that we had with it, mainly because our office did so much maternity care. But then when they were able to make maternity care out of basket, then it became a better model for us. And honestly, for us, it was truly COVID that sealed the deal for us, because virtual care paid so poorly, and the numbers that Alberta Health were giving us and showing, because we had a very large office with a large patient panel, and we wanted to actually take on more patients. Same problem as what Brad says, because our community lost 5 doctors as well. So there was a number of reasons, but financial was a big one, where we finally pulled the plug. So
yeah, very good. We know that decision is not easy, and lots of thinking has to go into it. And so we really wanted to pick your brain, Brad and Mel, tonight about what should clinics consider or think about when they're making their decision process to join Blended Cap. And Brad, I'll have you go first again there.
Yeah, I mean, I think really spending time on the why. Why do you want to change over? What do you really what are you hoping to gain? What do you hope the relative advantage might be? And, spending a lot of time as a physician group or a clinic group exploring what the change means. So, specifically, does it mean change in the business structure and change in the payment? And, do you have a shared kind of mental model as a group on where you're going with blended capitation? And so, some of those types of considerations. I also think it's good to think about, where are you at right now? And as Melanie said, they'd had a lot of experience working with team and working with PCN and working on things like panel and medical home. And, I think if you have some of those foundational elements in place, that's going to make you more successful as well.
Mm-hmm. Mel, what do you think clinics should consider?
I think one of the big things is whether or not do you think you have a manager for your office who can do it for like really help you with it, because that's what we hear in regards to clinics that are having more difficulty, is if their manager's losing it and because it's a lot, right? So we had investigated Crowfoot's model a number of years before, so because we wanted to see how it would look, and I guess all I'd say is the other thing that worked in our favor for our office is that we sort of had an idea that team-based care could continue to happen because we had big offices that were meant to share 4 to 5 people per office, right? So, so sometimes you have to kind of think about your space and whether or not you can try to add team base to it, and or if you do, how you want it to look, right? So, because some of it can absolutely be virtual, more so than even more than it is already from COVID. So,
thank you so much for sharing that with us. Let's go into the next slide, and we'll have a little pit stop around what is the model and who are the partners. So it's a partnership with Alberta Health Services, and the Alberta Medical Association. This is the ARP for primary care to support the patient's medical home model that we're testing. So it's the partnership with 3 stakeholders. You are probably very familiar with this graphic and how it supports the patient's medical home. Maybe you've never read in the little gray section, the foundational section, there's a category called system level supports. And when you read in that real base for the patient's medical home, it has the term supportive payment structures. And that's where we're testing the patient's, the blended capitation model, is we want to have very supportive payment structures that enable all the great work that happens in patients' medical homes, enable all the work in those elements, and drive the behavior and support that behavior in the patient's medical home. So having a payment structure that matches the wishes that Mel and Brad were chatting about. We'll also do just a little pit stop on what do we mean by capitation. So we're talking about a blended capitation model. And so what is capitation? The blended capitation model is very, it does actually have more formalized processes when it comes to panel. So when you think about panel, it is a rostered or affiliated group of patients. And so it's a validated panel. The patient agrees that they are your patient, and the providers agree that they are your patient. So once that's underway and you have an affiliated patient group, each person in the panel has a capitation rate assigned, or the projected health system cost. And that's based on the patient's age, their gender, their utilization, and their complexity. And then the clinics are paid based on this panel, with each person having that capitation rate. And it's calculated through what we call health profile groupings using the Canadian Institute for Health Information, or CIHI. And it actually is quite sophisticated. You can get almost up to 10,000 cohorts when this capitation rate is calculated for the panel. That's the word capitation, but blended really is a blend of that capitation and a fee for service. So the capitation money flows to the clinic, not to the provider. So that's one note to think about. And then the capitation, as I said, the payment is upfront, even before seeing the patient. And the term blended is really to indicate the capitation part of payment and the fee for service part. Again, that capitation is based on the clinical acuity and age and gender from that health profile grouping from CIHI. The clinic gets 85% of the cap rate in 24 installments, and then the physicians are also paid 15% of fee for service to add up to that 100% cap rate. So it actually can eliminate the whites of the eyes in some circumstances. And when you look at the little pictures at the bottom, that's what it's meant to indicate. The big dollar sign is that 85% of the cap rate that goes to the clinic. And then you may or may not have to see the patient. But if the patient does come in, then you see that the patient comes in and you bill that 15% fee for service and back. The money comes back to you. So that's it in just a little brief description. We wanted to kind of work through the elements of the patient's medical home and ask Mel and Brad, as we go through these elements of the patient's medical home, how and what they've done with the blended cap model to support these elements. So we'll start with engaged leadership and capacity for improvement. And we've already heard some of the things that Mel and Brad were speaking about. So we'll go to the next slide and ask them a couple of things. One is, what were the practice model and clinic model changes that your team needed to do? And then how did the collaboration and relationship between the physicians change? And if you want, Mel, we'll start with you. We'll just change it up a little bit, be a little jazzy, and start with you, and then we'll go to Brad.
So in general terms, I mean, you kind of had to have, for us, we had to have two separate kind of groups to make it happen. So we actually had a financial group that kind of reviewed how we could see how the numbers looked, and partly because essentially in our office, we have so many physicians doing so many things outside of the office, whether it was hospital-based medicine, delivering babies, or actually PCN clinics, whatever, right? So in general, all of the physicians were only in the office 3 days a week. So for the financial part, we had to look at that if we're all being paid a certain capitation rate for our patients, then if our patients are seen by someone else in the office, how is that going to look, right? So we had sort of an internal, we call it internal negation, and then we call it contribution if another, that you get paid if you actually see someone else's patient. So that was quite complex. I will be honest, it took a number of months to figure it out, but it's partly because we were one of the newer clinics to do it. There was really, I think, only 3 or 4 other clinics that we kind of reviewed. So, and I think that's the point of the ACT team, is to make it so it's easy. And then the clinical model part was to basically look and say, hey, we already had great team-based care, but how can we make it even better? Because we really wanted to make it so that more and more patients were seen by the team, and not necessarily by the doctor for the stuff they don't really need to be, right? So really that's kind of from that part. And our collaboration of the relationships, the big deal from our end is that BCM needed everybody to say yes to it. You couldn't actually have one doc in your clinic saying they didn't want to do it. So it was a big step for all of our owners and associates to consider to do it. We kept selling that we could bow out at any time and go back to fee for service, and that seemed to do the trick. And actually, when we were able to look at the financial modeling, we could show that everybody would be making more money and in a variable amount, but it was more. And so it made it so we were able to convince them to try and change out of a fee for service mindset. So
great. Thanks, Mel, for that. Brad, what are your thoughts on those two questions?
Yeah, I mean, I won't repeat what Mel said, which is all true. I mean, we redid our practice agreement because suddenly the money is flowing in a one big lump sum versus, assigned to individual docs. And there's a lot of philosophical discussions around fairness that happen. And so, we kind of rebuilt our practice agreement from the ground up. In the clinical model changes, we had a vision of where we wanted to go for several years. And so we were pretty aggressive in upskilling mostly our nursing teams, so our RN and LPN team, to take on more clinical medicine. Quickly moved to our RNs prescribing in our clinic and really trying to maximize how the team supports the panel. Collaboration wise, you do need to be on the same page. I think in this model, you're kind of collectively successful or collectively unsuccessful. And so you need to have a comfort level of communicating with each other when, maybe one person is an outlier, either in the way they practice or the way that they bill. And, they need to be open to kind of some support and change. And so I think we're even more collaborative because we want to be successful as a group. And I think, the more collaborative you can be as a clinician team, the more successful you are.
Thank you both. We'll move into a couple of more elements of the patient's medical home. We'll have we're going to hone in on the panel and continuity element. So as we mentioned, panel is a little more formalized in a blended cap model with that affiliation or rostering of the panel. And then continuity, relational continuity, can actually impact your payment as well. When we look at continuity, knowing that relational continuity increases, mortality decreases. And so it is a goal of the blended cap model to enhance the continuity, relational continuity, because of this important piece. This is Alberta data. You see this in other jurisdictions, and it actually does more than just decrease mortality. And so it is a goal of the blended cap model to have that relational continuity piece sound. And so I wanted to share a little bit more with the group about that. So thinking about continuity driving financial pluses and minuses, the fee-for-service side, well, patients see their own doctor, payment is received. No payments received when the patients see team members, and no payments are received when your patient seeks care elsewhere. And in fact, one could argue that in that discontinuity, you are losing money, and it's just a silent kind of loss of money that you may not be recognizing. With blended capitation, we shared with you that the capitation payment is received regardless if the patient sees their own doctor or the interdisciplinary team. And you heard Brad and Mel talk about how you can see that patient can see doctors within the same blended cap clinic as well. And so 100% continuity to clinic means 100% of that pay, the 85% capitation plus fee for service. What does happen though is if a patient seeks care elsewhere from another primary care physician, because capitation was paid up front, a thing that occurs is called negation. And money is taken away from the clinic when that occurs. We call it negation, and it's when that patient seeks care from primary care elsewhere for the in-basket of services. The system doesn't pay twice for it, and they get negated. Having said that, though, it doesn't occur the first year. And so there's lots of processes and things that clinics can think about and do to strengthen that continuity piece, the relational continuity piece with their patients. And so I really wanted to ask Mel and Brad, around that piece, what processes did you and the clinic put in place to enhance continuity and address negation? And I'll start with you, Brad, if you would.
Yeah, I mean, access is important in this model because, of course, you know, if you don't have decent access, it's hard to maintain decent continuity to your panel of patients. And so, you know, our clinic has worked on advanced access and access improvement for a very long time. And so we continued to kind of reinvigorate some of the measurement and processes we have to improve access to do this. The the other thing is just thinking about innovative ways to provide access, maybe to patients that travel for work, that type of thing. So again, virtual care and asynchronous care can really improve that continuity. And then, having a process in our clinic where we can deal with urgent same-day stuff effectively was another thing that we do. And lastly, we just try and bring as much care under our roof as we can. What are the things that people are seeking help elsewhere for? How do we build our own skill set and services so that they can seek that care under our own roof? So I think it was really a basket of things that we kind of put in place to try and deal with this.
Thanks for sharing that. Mel, what processes have your clinic done?
Yeah, I mean, access is the way you prevent negation, because you can make it so if you can see your patients, then they won't go elsewhere. In our community, we're lucky enough, we actually don't have really much for walk-in clinic. So it's interesting that the patients, do get their access. We actually have really tried to improve our access with our team-based model because we actually brought in pharmacists. So instead of nurses, so that the pharmacists do many appointments in a day themselves, right? So we were able to increase our team-based appointments from 1,500 a year to 3,000 a year just in 1 year of blended cap. So that's how we improved our access. The good news for anybody considering blended cap is, as Carrie said, you don't have any negation for your first year. So really you have plenty of time to kind of figure that out. And then not only that, you do receive reports all the time. So if you find out that you have a patient who is happily seeing some other doctor, you will find out very quickly and you can address it. You can call them and say, listen, bud, you got to see us or them, pick it, and kind of lay your line in the sand. So
thanks so much, Mel, for those great comments. And you have both talked about team-based care. So let's dig in even more. We're going to bundle enhanced access, team-based care, and patient-centered interactions. Because we know that you both have such excellent examples of how you're doing all of these three elements. And Brad and Mel talked about how blended cap model allows for more financial flexibility to be creative in how service is delivered to patients. And they've both spoken about examples or alluded to how they're optimizing their clinic team members and how that has actually supported their enhanced access and continuity. And so looking at this, we'll go into the next section and really unpack even more about that. Can you describe how your clinic's been creative with how your multidisciplinary team members provide patient services? And we know that you have been. And what have your patients been saying about this new way of delivering services? And Mel, why don't we start with you, if that's okay?
Yeah, so I mean, I don't know that it's creative, but the minute we went live with blended cap, we hired an NP. We actually were able to hire an NP. We stole her from our PCN. So there you go. That's how good we are anyway. But it really does help because it does improve access. And then we actually, over this last year, have just continually expanded. So we expanded our mental health services, which used to be like a day to 2 days a week, to now basically 4 to 5 days a week. So that's been helpful with that. And then, as I had said, we did have an RN for a very short period of time, but she actually just wasn't comfortable seeing patients and actually not having us see them, which is an interesting, so she really struggled with that. And so we actually ended up just deciding to expand our pharmacy services that we had. And we actually stole someone from Rexall who didn't love it there and decided to work with us instead. And it's been fabulous because we're basically being able to enact change as well within the clinic, where we are with our EMR, we're able to actually pull out diabetics that are on Jardiance or something like that and switching them to SGLT2 inhibitors instead because it's better for them and all of these kinds of things. So, and then they're really improving our access because they can do almost all the prescription refills. They do asthma education, they do mental health. My pharmacists are doing mental health. So it's been pretty fabulous. I highly, highly recommend pharmacists if you consider it. And our patients, honestly, they carry on how much they like our team. So it's been going really well. So.
Oh, thank you for that. See, you are creative. Thanks, Mel. Brad, what are your thoughts on these two questions?
Yeah, I mean, our general approach is that we want to maximize everyone's scope of practice to the fullest extent. And so, in my clinic, we do have an NP as well who carries their own panel of patients. We actually have 3 RNs and 2 LPNs as well, and they have full patient lists. So they see patients independently throughout the day. They have full schedules like all the physicians do. And we worked hard on building their kind of confidence and comfort level with seeing clinical problems independently, and they're supported by protocols for everything that they do. But you can see one of my nurses for everything from, a UTI or a cough and cold to, PAP test or a well child checkup to, mental health assessment or cognitive assessment, and kind of anything in between. And so we've leveraged our nursing team to kind of assist with the clinical load. They also help manage some of our really, really complex patients, especially socially complex patients. They have a navigation and case management function as well. You can get assigned as a patient to case management at our clinic, which will get you kind of connected with one of our nursing team. We have experimented and had pharmacists working with us as well, trying all kinds of different ways to leverage them. And, we do have a fairly significant mental health team that works with us for our PCN too. And, some of the things that we've really done is try and remove any barriers to getting into team members. They just flow directly into the provider that makes the most sense at the time. And we have really good communication protocols and care planning protocols to keep everyone in the loop. So, it's something we talk about every month. What else do we want to do? What do people have interest in? What do people need more help with, more confidence with? But you can get quite creative. I actually think it's as much finding the right person as the right discipline. So I think there's overlap between what NPs and pharmacists and RNs and LPNs can do. And it's as much around finding the person with the right mindset and that willingness to be creative and how they contribute to the team as it is the actual role itself, and their training background.
Love it. And did you have anything to say about maybe what your patients are saying about it, Brad?
Yeah, I think, we had pretty good patient feedback before we switched over, but we do patient surveys, and through the HUCA tool, we did them when we went live on BCM and continued to do them yearly. And, we did see some improvements in that feedback, mostly around really liking the ability to see people, that make good sense to see for the problem that they have. And they also really liked things like messaging and video, phone appointments. This is pre-COVID stuff now, Carrie, that we were doing. So they like the flexibility, they like the team, and they feel feel a different vibe when they come in, I think, is a good way to put it.
Thank you both for that. I wanted to do a follow-up question. And so I'm trying to think about maybe the participants in the group, and they may have this question for you. Who do you think is a good fit for the blended cap model? And Brad, I'll start with you this time.
Yeah, I mean, I think if you have interest in working with others and working as a team, and you see a future where you're sharing work with team members, that's a good fit. I think if you have that internal muscle for change, that ability to adapt, that kind of quality improvement mindset. If you've had experience with team members with your PCN and found that positive, if you have had experience in access improvement and been able to do some of those things and really feel like you have some of the fundamentals in place, like panel processes and good relationship with your support team at your PCN. Those are some of the things that I would think about being a good fit for PCN.
Thanks so much. Mel, what are your thoughts? Who do you think is a good fit? Some people might be wondering.
Well, I think we could all say anybody, right? You don't actually have to love team-based care to do BCM, but it just makes your life, that's the point of battling the burnout, right? Is making it so others do stuff for you. But I guess the big thing I would say is that I actually think you need a good EMR, and you need as I'd said before, you actually need a manager, or if you don't have a manager and it's one of your physicians, here's hoping they know what they're doing, because I make fun that we're doctors, not business people, but there are some doctors who can be business people. I get it. So yeah, short and sweet. So
yeah, thanks so much, both of you. And we'll have Christine Doe just mention a few things very quickly about the supports that Mel and Brad were referring to. Next steps if you have a curiosity. So I'll just pass it off to you, Christine.
Thanks so much, Carrie. So these are the supports that are provided to BCM clinics. AMA Act assists at the clinic level with process redesign and change management. For example, because BCM takes away the whites of the eyes rule, the way in which patients can be booked can change, and we can help with the decision-making tools for booking and patient scripting. We also host a community of practice for BCM clinics and clinics that will soon be joining the model. And it has been such a great forum where clinics collaborate and they connect on suggestions, ideas, and shared experiences. AMA Act and health economic support with billing questions and drafting new or enhanced practice agreements with BCM clinics. And that includes the financial distribution conversations that Brad had kind of alluded to there too. And then Alberta Health performs the financial modeling for interested clinics and set up the technical enablers of the model for payments, billing, and reporting. They also provide the forms and other details, including the ministerial order that forms the basis of their contractual obligations to the province. So we all come together regularly to ensure that clinics are ready for the changes when they go live with BCM, and we continue to support the clinics after they transition to the model too. So overall, we are learning together as a team, and Alberta Health has been really great to partner with. On the next slide is the clinic journey from curiosity to implementation. So if a clinic is interested in learning more about BCM, the first step is initial contact. So our team can be reached through email and through the ACT website. And if you actually scan this QR code on the slide, it will direct you to the BCM page on the ACT website. Next, our team will meet with the clinic just to get to know them and learn more about their passions and what they're looking for. And then we will provide a formal orientation and have a discussion with the clinic to answer any questions that they have about BCM. If the clinic chooses to go to the next step, Alberta Health has a good way of conducting the financial modeling. And this gives clinics the opportunity to compare their compensation on fee-for-service to what it would be if the clinic transitioned to BCM. And Mel had mentioned that when they had done that, they actually learned that they made more on that blended cap. So this is an opportunity to see that comparison. And then after financial modeling, if a clinic is interested in pursuing BCM, there is an application process that we can support with. And then is the implementation of BCM, which our team supports at the clinic level, and again, with that community of practice. So we all support clinics along this whole journey and after the clinics have implemented BCM. This is just a snip of what our BCM page on the ACT website looks like, and we will share a direct link in the chat. But on this page, you'll be able to find out information about BCM, including the key steps to get started and how to enroll. And then we also have some YouTube clips featuring physicians from clinics that are on BCM. So you'll be able to see and hear what your colleagues are saying about the model. We just wanted to highlight a few key messages. So the blended capitation model supports the patient's medical home, and the model allows for more financial flexibility to be creative in how service is delivered to patients. There are supports provided by AMA for change management, process redesign, and practice agreement development. Physicians can go back to fee-for-service at any time during the process. And the AHAMA Alternative Relationship Plan Working Group is being established to inform on clinical ARP policy and on ARP models. So that's really great because now there can be feedback and improvements made to those ARP models. That concludes our presentation.